Beh. Aquí també. Molt bé. Vale. Okay, merci. Okay, so good afternoon. First of all, I want to apologize for not being there in Barcelona because of the problems in the outdoor that has been occurred. But I will also say that there will be no interruptions, so we wouldn't have a break. I will explain all the class without break. So if anyone has any doubt or doesn't follow any slide, please take note of that and send me an email, and I will answer, of course. So today we will abord the mechanical ventilation, which is something relatively specific in the respiratory diseases. We have talked about medication inhaled, oxygen therapy, and the pulmonary function test. That is something general for all the respiratory diseases, but in that case, mechanical ventilation, it's very specific for patients in the intensive care unit. So first of all, we have to ask is what is a ventilator or what is a ventilation unit? And this is a machine that will take air inside the lung. So the first thing that you have to know is that the ventilation units give positive pressure. If you remember, when we are breathing during the inspiration, we perform a negative pressure, and then during the expiration, we perform a positive pressure. And in that case, it's the opposite. During the inspiration, the ventilation is throwing via a positive pressure, and during the expiration, it's exhaling with a negative pressure. So the first thing that we should know we have to know how it works, this ventilation unit. And a ventilation unit, it's a device, a modern device. There are old ones, but nowadays we have extremely new softwares with tactile screens, and there are several companies that are making different kind of machines. But if we have to separate how the air arrives through the patient, because you have to know each part of the air traveling, let's say like that. So first of all, we have some screen with buttons, and it's something that we will always look at the parameters that are performing the patient, and also the parameters that has been set it for the by the chest physicians or intensivists. So, and also some curves, some graphics regarding the properties of the inspiration, but this is something that is not really important right now. After that, we have the circuits, because the air comes out from the ventilation unit and has to go through the patient, and it's by those circuits we have an inspiratory and also an expiratory circuit. Then we have also a filter, which is something extremely important because we have to protect the patient, but at the same time we have to protect also the ventilation unit, because we don't have ventilation unit for every patient. So it is very important, the protection of the machine and also, of course, the patient. Those are some examples that the main objective of that is to filter, and some of them Could have also the objective to hot the air or warm the air, because something that you should know is that the ventilation unit gives air, but that air is extremely dry. And as you know, when we are taking an inspiration, or the air that we have inside of our lungs are humid air and also warm air, 37 Celsius degrees, and more or less it's 90% of humidity, of relative humidity. And because of that, something also very important that has been proved many years ago is the importance of humidification. And the humidification is a device that it goes with the ventilation unit. And if you see in that picture, we have the air that is going out from the machine, has to pass through the humidification device, and who is being humidified and also warmed, and then the air can go through the patient. And why it's so important, humidification? The first, or probably the most important thing regarding humidification is when it is not sufficient, because we have seen that the mucociliary clearance, its efficacy, it's getting down, it's getting worse, because the cilia, the ciliated cilia, if the mucus it's too viscous, has more difficulty to remove the airway, the secretion towards the mouth. Of course, that the increase of the secretion viscosity, it could be some loss of surfactant, but it is something not very, very important. Something that it's common is the atelectasis, or also the tube occlusion, because if the secretion remains too much viscous, it could block or obstruct an airway, or also the tube, because we will see right now that the patients where are being ventilated has a tube inside their airways. And less usual, but not less important, is the humidification is in excess. We have too humidified. We can have mucus dilution. We could provoke more difficulty also to remove that secretion because it's too fluid. So the ciliated cells are unable to remove toward the mouth. So what happens when the air goes out from the ventilation unit, past the circuit, the filter, the humidification, and finally have to go inside the lungs? Well, we have two types of ventilation. We will separate into invasive ventilation and non-invasive ventilation. Obviously, the first step of the intensive care unit, it's normally the invasive ventilation. And we will have a tube that will go from the exterior to the interior of the airways. We will have a endotracheal tube, nasotracheal tube, or also a tracheostomy, which is a surgical process that is being produced in the trachea and will pass a little tube inside the airways. And also, if we do not have to be invasive, we can also perform a ventilation with a non-invasive device or non-invasive interaction. It could be a facial mask, nasal mask, and nasal pillows, depending on the physiognomy of the patient's shape. Okay, so here are some examples. This is two figures where we can see an endotracheal tube. It is going through the mouth and larynx, pharynx, and also inside the trachea. And this is called a cuff. And this cuff, it is insufflated when we have performed the intubation, and it's extremely important to protect the airways. We will talk about that later. And the other picture is the tracheostomy, that you will see that the tube pass through the trachea, directly through the trachea, do not pass between the vocal cords, but also has that important thing that is the cuff, yeah, to protect the inferior airways. Something that is anecdotal is that the endotracheal tube that pass between the vocal cords has something usual. It's when the patients are being extubated, has that called voice box, yeah, which is there is because the vocal cords could be a little bit irritated, yeah, or inflamed. So the first thing that we had to know is why someone would need a ventilation. Why is so important ventilation? Well, the most important thing is depending or non-depending on the disease that has provoked to a patient to go through an intensive care unit. Something that is common on all those critical patients is that they aren't able to breathe. So if we aren't able to breathe, we wouldn't have the opportunity to perform an effective ventilation, and on the same way an effective gas exchange. So that will lead to a respiratory insufficiency. So the first thing of the mechanical ventilation is to try to treat the respiratory insufficiency. Even if the origin has been a traumatic process or a traffic accident or a stroke, or doesn't matter, or something, or a respiratory disease on itself, the first thing is try to correct or to treat the respiratory insufficiency. And also, that when I was talking about the cough, why it is important. So when those patients arrive to the critical care unit, very commonly they has a very low level of conscience. And when we have those low levels of conscience, our glottis doesn't has the reaction to protect our airways. So it's for that reason that it's very important to protect them, because the airway system is something that is sterile. So if the glottis do not protect that, any foreign body or secretions or gastric elements could go inside the airways and provoke other problems or contraindications or, in fact, infections. So how we can ventilate a patient? The first thing that we have to know is we can ventilate in different modes, but we will explain in general. But the only thing that you have to know is we can deliver the ventilation via a pressure mode or a volume mode. How to explain that? In fact, when we are breathing, we inhale a volume, and that volume performs a pressure variation. Yeah, we have talked about that. Yeah, we increase our volume, and at the same time there is an increase of pressure, negative, but there is an increase of pressure inside our lungs. In artificial mode, this cannot be done. So we have to fix one of the variables. So or we fix the pressure, or we fix the volume. And what is the explanation for that? In fact, we set the parameters, and we will set to the ventilation mode in terms of, okay, we will fix the pressure until, let's say, 15 centimeters of water, and the ventilation unit will deliver air until we arrive to those variations, until we arrive to 15 centimeters of water. So we wouldn't know how much volume we will arrive to the lungs. And on the opposite side, we can set regarding the volume. We can set on saying you will deliver 5,000 milliliters of air, and the machine will deliver 500 milliliters of air without knowing the variation of pressure, okay? But when we want to ventilate in an artificial way, we have to fix only one variable, okay? You just have to know that. Knowing that, we will talk in general, very, very general, the different ventilation modes, because there are many criteria and many ways to say different kind of modes. But we will talk in a general way. We will have those 4 ventilation modes. The first one is the control ventilation. First of all, let me say that when we talk about ventilation, let's say that when the patient arrives to the critical care unit, very usually is unconscious. So, and it's very life-threatening. So it is very important to control all. So in terms of ventilation, it means that on the first step, the ventilation has to perform all the work, and the patient usually is completely sedated, so doesn't do anything. So, and during the treatment or the evolution of the principal disease, the work of the ventilator decreased and the work performed by the patient increased. Okay, let's say that at the beginning the ventilation work is like that, and the ventilation work of the patient is like that, and during the pass of the days and the evolution of the disease is going on that way, and finally the objective is that the work, all the respiration work has to be performed by the patient and not by the ventilation. Otherwise, it's to have the objective to extubate, to leave to get out the tube. So the first step, control ventilation, is the first mode of ventilation, and a key word or key phrase is that it's the substitution of the spontaneous breathing. So the patient does nothing. So we have to set, or the intensivist or the chest physician has to set all of the parameters. And when we talk about all of the parameters, we will talk about volume or pressure and respiratory rate. Yeah, so we will set, for example, you will deliver 15 times during a minute 500 of milliliters, and the ventilation unit will deliver exactly that, 15 times during a minute 500 milliliters each time, okay, and nothing more. Another type of ventilation is on the next step, where the patient is not sedated or relaxed because of the drugs. It's a system that when the patient starts to wake up, so it starts to perform just a little respiratory efforts, but very, very, very little. But of course, as a muscle, we want to activate them. So another objective of the intensive care unit is to decrease the sedation levels, to increase the cooperation and the activation of the patients. So on that ventilation mode, the patient, something different, or the key of the difference between the first one and that second one is that the patient are able to activate a cycle. And when we talk a cycle, it's something that has been predetermined. Yeah, on the previous one, we said that we have to set a parameter, X volume or pressure, it doesn't matter, a volume and a frequency, and it is called a cycle, okay? And let's say that if the patient are able to activate, to perform just a little effort, muscle effort, the ventilation unit will deliver a cycle, okay? And how it does it? How does it, or how can activate that cycle. It's via that system which is called trigger. It's an inspiratory cycle activation system. It's something integrated in the ventilation unit. And in fact, the objective of that system is to know or to perceive the ventilation effort, even if it is so low. 0.5 milliliter of water, which is something extremely low, for example. But you have to set it. And how does it work, that trigger? We have two ways to perform that. Or the trigger is by pressure, or it is by flow, okay? The behavior or the system mode, it's more or less the same, but one of them will activate when there is a pressure variation, and the other one will be activated if there is a difference on the flow. Yeah? But the system is exactly the same. In fact, when we talk about ventilation mode, we have to know that it's a closed system. So the pressure and the volume and the flow remain stable, always. Yeah, it is very important to remain stable. And if the patient performs just a little effort, but a very, very, very little effort, on the graphics, we will see something like that. I think that it's difficult to see, but we will see a little depressure. It's negative pressure. And we know that the physiological inspiration is with negative pressure. So if the system notice that there is a negative pressure, we'll think or we'll know that the patient has performed an effort. So at that time, the ventilation unit will deliver a cycle. So it means that if, for example, if it is set it 15 times 500 milliliters, if the patient do not perform any effort, the ventilation unit will deliver 515 times. But if the patient performed one effort, the ventilation will have delivered 16 times 500 milliliters. Yeah, 2 efforts, 17 times. Okay, so it's an addition. It's a cycle addition. Yeah? The other way is the flow trigger. Remaining the same explanation, it's a closed system, so the same inspiratory volume that goes inside the lungs has to be the same expiratory flow that goes out. Yeah, 500, 500, 500, 500. If arrives a moment that the inspiration flow is bigger than the expiration flow, it means that the patient has performed also an effort, even if the difference is 10 milliliters. At the same time, the ventilation unit will notice that activation, or will notice that effort, and will deliver a cycle. This is a graphical, but it's not very important. The only thing that you have to know regarding that is all of those negative pressure means that the cycle has been activated by the patient. And if the patient get asleep, for example, or get tired and is not able to perform an effort, because we have some predetermined cycles, the machine will deliver a cycle, but without being activated. Okay, this is the explanation of that little negative pressure. Another system is the intermittent, a system-controlled ventilation. In that case, let's imagine that the patient is getting more and more awake, getting more and more active, so it's able to perform more important inspirations and expirations, but not sufficient to breathe normally or to breathe spontaneously. So that system permits or allows spontaneous breathing, but within the regulated cycles. So it means that we will set also minimal cycles, minimal frequency or respiratory rate, but in the middle of those cycles, the patient are able to perform spontaneous breathing. That it will be not sufficient, but because we have that, we will be assured. Yeah. And normally, if the strength of the patient is getting bigger and bigger and is able to perform more important inspirations and expirations, the assisted cycles will decrease and the spontaneous cycles will increase. But the same as the opposite. If the patient is getting tired, the assisted cycles will increase and the spontaneous cycles will decrease. Yeah, it is something. It's a machine, but it's a very intelligent machine. So here we can see negative pressure and a predetermined cycle. So this is a setted cycle. Yeah, and here we will call that a spontaneous cycle. We can see that there is a negative pressure, so it's a little inspiration and a little expiration. Yeah, but it's a little one. Yeah, you can see that the difference between that one and that one is the setted one, which is an important or is a normal breathing, and in fact there is a very low respiration effort. But we have to keep it, and we have to try to improve those efforts. And at the same time, if the patient is not able to perform a spontaneous breath, and also if not able to activate a predetermined cycle, because we have predetermined cycles, let's say of emergency or to assure ventilation, if the patient doesn't do anything, the machine will deliver by itself a predetermined cycle. Yeah. So it's a way to assure an effective ventilation. And then we have the spontaneous mode, where it means that the patient has to be there are different kind of spontaneous mode, but today we will talk more deeply of those two, and the other ones we will pass quickly because there is something that we have talked about, and it is something that we will talk about. Yeah. So the two most important spontaneous mode is the pressure support ventilation and also the BPAP spontaneous ventilation. Something that is extremely important is that if we want to ventilate spontaneously a patient, the patient has to be completely awake and completely active. And why? So the reason is that the patient will decide on his own the frequency and the volume, or the frequency and the volume inspirated. Yeah, and the only thing that will perform the machine is try to relax or to help the respiratory work, respiratory muscles work. So let's talk about pressure support ventilation. It means that when the patient tries to breathe, the machine just leave a little help in terms of pressure. Yeah, there's a bolus of air bolus to increase the tidal volume. Yeah. So it will be regulated by pressure, as I said. Patient has to be awake and active, but it's something general for all the spontaneous modes. And of course, reduce the respiratory work. As I said previously, the objective is to extubate the patients to perform the weaning process to leave the tube, but we need that the patient support or are able to breathe on his own spontaneously. So it means that his muscles, his respiratory muscles, um, has to perform it works normally. Yeah. So on the first steps of this spontaneous ventilation, the muscles could be tired or could decrease its strength, and the pressure support ventilation or the ventilation during the spontaneous modes will help to reduce that work. So that will help the process of the weaning of the extubation. Something that you have to notice here is that all the cycles or all the inspirations has been activated by the patient, and something also that will give us the information that is the patient who is deciding the respiratory length, respiratory volume, and also frequency. This is an inspiration and expiration. Yeah, this is the same. But if you see the length of the inspiration, expiration, it's not the same. Yeah. So it means that it hasn't been delivered by the ventilation unit. The ventilation unit, it's very clear, is very specific. 1.3 seconds inspiration, 1.8 seconds expiration. Yeah. But in spontaneous breath, we do not decide how many seconds we want to inspirate and expirate. Yeah, we breathe and that's it. So here we can see the difference on the length of respiration. So it means that it's the patient who is breathing, and the only thing that is doing the machine is the help. Yeah, but the help, because it is performing by the machine, it's always the same, because we set the pressure help for the machine, and it is set at, let's say, 10 centimeters of water, and the ventilation will deliver every inspiration the same level of pressure, always. Why it's important, the pressure support in the physiological effects? Because if we want to extubate, and if we want that the patient becomes sufficient to breathe by itself, we need to help, and we need to reduce the work. And probably the most important thing is the diaphragmatic work. The diaphragm as a muscle, if it's sleep by sedation or whatever, if it is not working, there is a decrease on their strength as any muscle of our body. So we cannot say, okay, you patient, you will start to breathe now. Yeah, it is impossible. The diaphragm has to adapt to the respiratory effort again. So we have to help it. We need to increase little by little the effort of the diaphragm. Yeah. So it is probably the most important objective of the pressure support. Obviously, if the diaphragm is working badly, the respiratory frequency will increase and also will lead to fatigue. Yeah. So it is something that goes together or are very close. Yeah. The other one, the ventilation on two levels of pressures, BPAP, it means B pressure airway, yeah? It's a B level of pressure. And the only difference, probably it is exactly the same, but the difference is it's more useful on the graphics. The only difference is on the previous one, the pressure support start at 0 pressure, and there is an increase during the inspiration, and during the expiration arrives to 0 again. And it has been shown that if the ventilation arrives to 0, sometimes could lead to an obstruction or airway obstruction, yeah, or could lead to a little atelectasis. So the principle to remain just a little positive pressure during the expiration, yeah, that the 2 levels of pressure, this leads to avoid bronchospasm. So nowadays, let's say that all the spontaneous modes are on this way, are working on that with that kind of ventilation, the level of pressure, yeah, to avoid the possibility of bronchospasm, and then the expiration helps is exactly the same. So probably this is the most important thing, or the most important difference between them. Yeah? They are both by pressure. They're both permit the patient to decide the frequency and the volume exactly the same. The patient has to be activated and also has to be conscious, awake, etc. And the only difference is that, yeah, the pressure during the expiration. As I said, the other modes of ventilation I will pass very quickly, because we have talked about CPAP ventilation, and in fact it's not a real mode of ventilation. It's only a continuous positive pressure during the respiration. And if you remember, we have talked about them with those kind of patients, yeah, the obstructive syndrome apnea, hypopnea, yeah, and this is the gold standard treatment. It's CPAP, yeah. Is that the one? This is Busignac, Belgium one. And the other one is the IPV, spontaneous ventilation, which is this type of ventilation that is used for or to drain secretions, because it's a method that works with very high flows in a short space of time. It's like, yeah, with a device that we will see just now, which is with an electric diaphragm, yeah. And it is used in cystic fibrosis and could facilitate or ease the expulsion or the removal of secretions. Is that, and the device is that, it's called Phasitron. But we will talk about that when on the second semester, when we talk about the electric devices, or, well, devices that help to the respiratory physiotherapy. But it's something that we will talk about later on the second semester. We will cover that in another classes. And as I said, it is very important to protect the airways. It's very important to treat the respiratory insufficiency, because that patient arrives in a really critical state, and we have to cover that. But at the same time, being intubated, has a tube inside our lungs, is very harmful, extremely harmful. This has a lot of complications and increased mortality and increased hospital admissions, etc., and also other things that we will see right now. So the first thing from the first day is to have the objective to extubate as soon as possible. Yeah. So that time, or that balance that I have talked about, respiratory works or ventilator unit works and patient works, has to be as fast as possible on that way. It's always like that, but has to be the objective. Because when we talk about intubation, there are several times that we could have different kind of problems. The first one, or the first frame, is when the patient is being intubated. It could happen in the street, it could happen in the road, it could happen also in the hospital, but usually are maneuvers that are being produced during an emergency. So are maneuvers that are being performed very fast and could lead to different problems. The first thing is oral or teeth injuries. Yeah, you have to use your laryngoscope and put it in your mouth and then put it up and try to introduce the tube. But imagine that is an accident and you have different kind of foreign objects in your mouth and you have to go quick. So there are several injuries that could appear. Also, something very usual is an esophageal intubation. Remember that when you are crossing your larynx, there are two ways, or the esophagus or the trachea. But if you go fast, you can go through the esophagus. This is one of the reasons that when you have intubate with an AMBU, you have to perform an insufflation and look at if the insufflation is being performed on the thorax or on the stomach. Yeah, we will tell you where are you. Another thing is during the process of the loss of conscience, the control of the glottis is lost, completely lost. And also sometimes those patients with the lower level of conscience could vomit or also could have some materials inside their mouth. And if there is no that control, glottis control, sorry, we have several times the problem of aspiration or aspirate the to vomit and the aspirate that. And in fact, that provokes extremely complication or very high infections, pulmonary infections that could lead to pneumonia or parapneumonia or emphysema or other complicated phases of the respiratory infections. And also during the time of the intubation, the patient is not breathing. So if the intubation is getting too long, there is a high risk of hypoxia. Is a hypoxemia directly produced by the lung of the intubation, and the hypoxemia will lead to an hypoxia. Yeah. But probably the most important problems is during the ventilation, during the intubation, sorry. Because as we have a tube inside our lungs, even if we do not have any respiratory disease, the respiratory system reacts very heavily to that. And the first thing is that the respiratory system will start to produce a lot of secretions, will start to hyper secrete. Yeah? And the excess of secretions will lead to the possibility of obstruction, airways obstruction, and if there is airways obstruction, there will be more possibilities of infection or atelectasis. Imagine that the secretions block or obstruct an airway, so there wouldn't be air that arrives back on the backside of that obstruction. So on that space, the lungs will perform that, yeah, obstruction. So it's atelectasis, you know that. Another thing is during the intubation, sometimes the tube could be in contact with the airway walls because it is something that we could not interfere on that. And it could provoke some mucosa problems or also laryngeal problems. Something that it's extremely frequent, it's the nosocomial infections. If you remember, when we have talked about pneumonia, we said that nosocomial infections is the infections that you get inside the hospital 24 hours later of your admission. And if you remember, we have talked about that, we have said that 90% of the nosocomial infection is provoked by the ventilation. Yeah. Again, during the intubation, something that is very common or it's extremely physiological is that if my muscles are stopping to perform their work, they will be very soft. They will be very good because they do not have to work. So, and of course, this is a physiological problem, but the respiratory muscles very quickly start to decrease our activation or decrease their work and also their strength. And of course, the more time you are being intubated, the more time you will remain at the hospital, and therefore the increase of mortality. On that figure, I do not think if it is clear, but in fact it is said that the probability of survival and related with the days from the start of mechanical ventilation. And in fact, it is all from respiratory diseases, but it's the same with other diseases. Here you can see it's 50% of probability to die arrive just at between 13 and 15 days of mechanical ventilation. So it is extremely important to try to extubate as soon as possible. But there is not the only problem to extubate, because during the extubation there's also problems that could appear. Probably the most typical ones is the aspiration, because if we relieve the tube and it remain their secretions remaining upward the cuff, those secretions or even another material could go down and could go inside the lungs and provoke an infection. But probably the most typical one is also the problems related with the inflammation. Yeah, let's say here laryngeal spasms, laryngeal and subglottic edema, mucosa problems, and tracheal inflammation. Less normal. Let's say those three are very typical, and also a vocal cords paralysis or vocal cords injuries. In fact, when we relieve the tube, very commonly we see the typical sound. It's called stridor, when the patient is breathing yeah, like that. It means that is a bronchospasm. It's a reduction of the diameter of the airways because of the inflammation. And if that inflammation is very, very important, it could be a dangerous state. Yeah? So we say that the extubation has to be one of our main objective, but when we can extubate? We can extubate when we want? No, of course. There are several protocols that has been proved or right or published that how a patient could achieve an extubation process. Yeah. So the first thing is try to perform as closer as possible an spontaneous ventilation. It is called the T-tube test. In fact, on that test or during that test, the patient are without ventilation and just remain the tube, the tracheal tube, and the patient try to breathe normally. Yeah, it is very close to physiological respiration. And during that test, there are several variables that the patient has to accomplish to try the extubation. Yeah, of course, low respiratory rate, a good saturation, a good ventilation, minute volume, heart rate, blood pressure, and something that is important for us, for respiratory physiotherapists, is to to know or to evaluate the effective of cough, wake, and the cooperation. And during the test, the patient has to accompany all of them. It doesn't care if there is a low respiratory rate and a low saturation. The patient could not be extubated. But if the patient has all those variables or accomplished all those variables, it could be extubated. But that is something that always goes well? No. Usually yes, because this is something that has been proved regarding that if the patient has all those variables accomplished, all of them, there is a positive rate or positive percentage of achieved successful extubation, but not always arrive on that way, because sometimes we could have the idea and the objective idea that the patient will support a physiological breathing, but when we extubate them, the diaphragm starts to, I wouldn't say being crazy, but starts to breathe not in a normal way and will fatigue very early. So what is the criteria to say that we have performed a successful extubation or not? No? If we have to perform re-intubation or another type of process that we will talk. So if there is a worsening of the respiratory parameters and those parameters do not improve fast in more or less 15 minutes, on the first 15 minutes, we have to think that we hasn't a successful extubation. Or if we have bad blood gas values that also persist for more than 2 hours, or if there is no accomplishment of those parameters, the blood gas values, that pH under 735, with it means an acidosis and will be accompanied of hypercapnia. And also something very important is the clinical signs of muscle fatigue. It's using the accessory respiratory muscles, sternocleids, escalens, etc., that will be very close to the increase of respiratory rate, which it means that the muscles are not does not achieve the demand of oxygen of the body, so they start to increase the respiratory rate, and also variables directly related with a poor gas exchange in terms of hypoxemia, which is low oxygen saturation or a oxygen pressure, arterial oxygen pressure, than less of 80, that will give us the information that we have a hypoxemia. You remember that between 100 and 80 it's normal pressure values, under 80 it's hypoxemia, and lower than 60 is a respiratory insufficiency. So if the patient are not able to maintain those parameters, we have two ways, or we have two process to perform, or a re-intubation, but with all the complications that has the intubation process, or try to ventilate again, but with another type of mode of ventilation, which is called the non-invasive ventilation. Why it is so important, the invasive ventilation or non-invasive ventilation? In terms of the spontaneous ventilation, we have the same criteria. That it means that the patient has to be awake and active. Obviously, the patient has to perform their own efforts, respiratory efforts, but the ventilation unit will help the inspiratory muscles. So when we can indicate non-invasive ventilation? Well, we have talked about the problems of an early extubation, which is extremely indicate to perform a non-invasive ventilation to avoid a re-intubation, and at the same time the problems of the complications of the intubation. Also auto-extubation, it could happens. And there are two situations very specific that will be indicated to perform on the first step non-invasive ventilation. And the most typical one is the COPD with hypercapnia. COPD, severe COPD has a typical shape, yeah, you remember, of the diaphragm, which is very flat. So it means that the strength of the diaphragm is not very good. So if we try to ventilate them and to avoid the work of the diaphragm, those patients very commonly aren't able to being disconnected from the ventilation, and they will remain ventilated for all of their life. So it's very important not to intubate that patients, the COPD. But all the patients could be ventilated with non-invasive modes? No. Only those patients that are active and cooperant. So lower level of conscience, agitation, coma, or for example in traffic accidents with important fascial fractures or fascial injuries, the patients are unable to have a mask, a facial mask or nasal mask or whatever. So the principal advantages is to avoid the complications of the intubation. It's extremely important: infections, speech problems, and the tracheostomy. Yeah. But assuring a correct ventilation, yeah, in those patients that could be difficulties to intubate, or in those patients that we wouldn't want, or we wouldn't decide to re-intubate because of the problems, or that problem that has been said. And of course, if you are being ventilated without an invasive interaction, your length stay in the hospital will decrease. And of course, if the time of hospitalization decrease, therefore there will be also a decrease of the mortality. And something in addition of that is the comfort of patient, because having a tube on your mouth or just having a mask, in terms of comfortability or quality of life, of course it's very different, because those patients with a facial mask could relive and could talk, could eat, yeah, could drink. So what can we do as a physiotherapist? Does we have a role in the intensive care unit? Of course, yes. It differs in different ways, but today here we will only cover the respiratory process, during the respiratory process, because on the second semester we will also talk about the specific work of the respiratory physiotherapist, but in general, in all the intensive care. So we'll talk about the mobility treatments and also the respiratory treatments. But regarding that, let's say that the implication of our work, in terms that as a physiotherapist we used to perform an active work, so we need very usually or very commonly the patient's cooperation. So this is inversely proportional. Yeah, the more activity, it's directly proportional. The more activity does the patient has, the more exercises or the more different kind of exercises we can also perform. So when we have in control mode that the patients aren't able to perform anything because they are completely sedated, our implication, even if we will perform some exercises and some important exercises, but our work, our frame our range of work is reduced. Yeah, we can perform 2-3 kind of exercises. And the more activate that becomes the patient, the more implications we will have. Obviously, during the spontaneous modes is when we will have a higher implication with different kind of exercises, very specific for cough, for draining airway secretions drain, for ventilation, for strength, etc., etc. So, in general terms, what will be what will be our objective or our key points of our work in those surveys? First of all, we have to think that patients who arrive at intensive care units, let's say that lose the pattern, ventilation pattern, it's very common that they are used to lose that. So as a physiotherapist, we have to learn again how to breathe, how to perform a good diaphragm movement, a good diaphragm effort, and a good pattern, good ventilation pattern. So we have to improve the ventilation mechanics, the ventilation strengths, and also to preserve that, and how to do it and at each step, at each phase, So we can also have something to say regarding the strength and control of respiratory muscles. We could explain or re-explain again how to breathe deeply or how to try to perform an effective cough, or how to breathe during the extubation process. We can have many roles in many phases of the ventilation, but obviously in the spontaneous ones. Something very important, extremely important, is the bronchial obstruction. We have said that during the ventilation, the first thing that happens is that our respiratory system starts to perform a hypersecretion, starts to has a lot of secretion. So, and those secretions very quickly could be infected or could be increased its viscosity. So it is very important to perform specific exercises to eliminate those secretions from the airways. Also, we have talked about that depending on the position of our diaphragm and our lungs, we can improve or the quantity of air, the volume, or the quantity or the difference or the ventilation. So just with some different postures, we can improve our ventilation. There is something used, for example, when those patients are in control modes, that they are unable to perform deep breaths or their diaphragms doesn't work normally. We can improve the ventilation or the volume putting them on different positions. You remember that, for example, on lateral decubitus, the superlateral lung will be more insufflated. We'll have more quantity of air. It could be useful, for example, for atelectasia, for example. So important to improve the pulmonary expansion and maintain it. And sometimes it's not very common to improve exercise tolerance. But we can also separate, because we are important during all the intubation process or intubation phase, but we have a specific role when or during the weaning process. And in fact, we have a role during the pre-extubation moment and just after post-extubation step or post-extubation phase. First of all, on the pre-extubation, we have to know that the mechanical ventilation mechanics are going well. Yeah, we have to control them. Also very important, we have to evaluate and objectivate the effectivity or the efficacy of the cough. Yeah, because once we have extubate, the only way for the patient to remove these secretions from the upper airways will be their own cough. So we have to verify that its cough is effective. Again, we have to prepare the muscles to being extubated. You remember when we have told about the T-tube test, we need to realize that those muscles, respiratory muscles, will support that effort of rebreathe again physiologically. And just after the extubation, we have to evaluate that all our work during the pre-extubation moment, it has been achieved. Yeah, and in fact, we have to avoid the accumulation of secretions, knowing or evaluating the by the confirmation of the cough efficacy, and also we can also perform some specific exercises to help for the secretions removal. That is something that, again, as I said, we will talk about on the second semester. And we have to control, very important, the respiratory effort. If you remember, when we have talked about the re-intubation process, we said that a variable that has to be evaluated is the accessory or respiratory fatigue. Yeah, so it means that if we observe during the post-extubation phase that the patient is starting to breathe not normally, to use too many times the respiratory accessory muscles, we have to deal with that and try to remember the pre-work that we have performed in terms of try to breathe with your diaphragm, try to use it very deeply, try not to increase your frequency rate. Yeah. And finally, in a practical way, during the non-invasive ventilation, let's say that the physician set the parameters, and then we have to start the ventilation. This is something that could be performed also for nurse, for medicine, and of course by the respiratory physiotherapists. First of all, or the first step, is to check that the material adapts to the different physiognomy of the patients. We have all different facial shapes. Yeah, more thin, more thick, yeah, more marked, more boned. So it is important to know the different masks with different materials, and we have to prove that we have set, or we have proved the exact mask for that patient. Yeah. Another thing is to put in the action, or to put in place, get in place that device, that mask, because it is important to, in fact, let's say that we do not have to say, okay, good morning. Yeah, here you have your mask. I attached them. Okay, on. See you in the afternoon. No, it's impossible to do that, because those machines deliver a lot of quantity of air, and we have to explain to our patient, now we will start the non-invasive ventilation with that mask. Here you can touch it, you can feel it. You will see how the air is delivered, because it's a high flow, and it's something that it could be harmful or not adapt to all of the patients. So we have to explain previously to attach, because we have to attach it heavily, to avoid lags. And And finally, as I said, we have to control the problems. For example, circuit leaks. Yeah, the as a closed system, if there are some leaks from the mask, the ventilation unit will think that the patient are performing extra extra breathing, so it's possible to the ventilation start to deliver more and more ventilation cycles. Or if the leak it's too big, the ventilation unit will stop to deliver air, and it will start a noisy alarm, so someone will see that. But in fact, the problem will be for the patient if the ventilation unit stops to deliver air. Also, the bad adaptation of the ventilation parameters. Sometimes the patients are, we call say, fighting against the ventilation because they do not breathe when the patient delivers air or something like that. There is an asynchrony. It's ventilation asynchrony. It's when the patient fight against the ventilation unit. But if we have performed that action good enough on the first step, on the first phase, usually we have less problems of the ventilation adaptation parameters. And finally, the presence of pressure ulcers. As I said, those masks have to be attached heavily, so it could appear some injuries that will provoke other problems, like the ventilation cannot be performed after or for several hours, for example. Okay, so that's it. I hope that you have enjoyed that class, and we will see after Christmas. And as I said at the beginning, if you have some doubt or something to ask me regarding the class of today, please send me an email and I will answer all your questions. Okay? Thank you. Bye.